Good afternoon, everyone. Thank you so much for joining us today for today's webinar on psychosocial issues with veterans at the end of life. This webinar will be recorded and available to view in the resource library. As a reminder, it is not too late to register for NHPCO's IDC 2023. IDC 2023 for NHPCO will be virtual. So we will be dropping the link in the chat box during this presentations if you're interested in participating this year. Just a reminder one more time, webinar will be recorded. Any materials shared will be attached on our website following this webinar. And we greatly appreciate you joining us today. I am so excited to introduce Dr. Elizabeth Holman. She serves as the palliative care psychologist at the Rocky Mountain Regional VA Medical Center and an assistant adjunct professor for the Department of Medicine at the University of Colorado School of Medicine. She is joined in her work today by Tootsie, a facility dog who brings comfort and support to the veterans they serve. She is also an associate of the nonprofit organization Moral Injury of Healthcare. She received her clinical psychology degree in 2008 from the University of Denver. She also holds a master's degree in theology from Cambridge University and a BA from Smith College. She came into psychology several years ago after other jobs, including serving as a mediator and child advocate in high conflict divorce and working on education policy. I viewed this webinar in advance and I absolutely loved it. And I hope you all will enjoy this webinar presentation live and recorded. Without further ado, please take it away.
Yay, thank you so much, Emily. And Catherine, I just really appreciate the invitation to be here today. It's such a gift to be talking with our hospice partners. I've been doing this work in palliative care with our veterans for 13 years now, which is sort of surprising to me. And we don't provide direct hospice services here at our VA. And so I'm just so tremendously grateful for the work that all of our hospice agency partners do to caring for our veterans. And so it's just really a gift to be able to be with you today and talk about just some of the psychosocial issues that our veterans experience. And I am going to, let's see, we practiced earlier sharing my screen. I should be cleared for this. I was laughing that like after 3 years of COVID, you would think that I would be more adept with Zoom, but there you go. So anyway, I'll go ahead and share my slides, which means I'm not able to see the chat, but I think Em is going to be able to kind of let me know what you're saying. And is anybody bothered by the simultaneous subtitles?
If you would like, I can get rid of that setting. Or you're good.
Okay, yeah, honestly, it got turned on one time. And I'm not always clear to how to take it off, and I want to be helpful to people, and I also don't want it to be distracting. So if you're able to take it off, that may be ideal. Thank you. So I'll go ahead and jump in. So yeah, so we're here to talk about veteran psychosocial issues at end of life. And just to give you a sense of what to expect, we're going to sort of talk about 4 major buckets. One is just general information about military culture and how serving in the military affects people throughout their lives, particularly end of life. Then we'll spend a few minutes talking about PTSD, because that's something, unfortunately, that a lot of our veterans grapple with. We're also going to spend some time talking about moral injury. That's something that is not as well known, but I think it's really important that we be aware of how the role that might play with our veterans. And finally, military sexual trauma, which is another thing that particularly can be really salient at end of life care. And as we go, if you have questions or comments, again, please put them in the chat, and we'll get them to me verbally. So just starting with unique considerations about veterans. One thing, and if you all are part of our hospice veteran partnership, I think this is probably not the case in your hospices, but you know that in our culture generally, a lot of times veterans are not recognized. So even just asking someone if they've served in the military and thanking them is tremendously important, particularly for our Vietnam veterans, right? Many of whom received a bitter response when they returned home, and for some of them have never been thanked or acknowledged. So that acknowledgement is tremendously important. It's important for us to know that military culture and training influences our veterans' life and their death. And we'll talk in a moment about battle mind and what that looks like. The other thing to know is that the influence of our military experiences may begin to surface as veterans age. So while they come home from their military service and kind of go on with their life, and their military service may not seem so salient, but as they go through the life cycle, and particularly as they experience illness, that influence can really come to the fore again. And life review, any of you working in hospice are familiar with life review and the importance and the healing power of life review, but it also can be really troublesome when experiences have to be integrated that people have had. And remembering that military experiences and relationships can be a great source of strength and comfort. Some of our veterans remain deeply attached to the people that they served with. And even if it's not someone they served with, just the presence of a fellow veteran can be really meaningful. I think in some hospices, there are veterans who volunteer really just to be present with other veterans. And that can, I heard a veteran say once, it's the same mud and the same blood. So there's this sense of a shared experience that's really powerful. So battle mind is a phrase that we use, and soldier training is really designed to arm individuals with survival skills and the skills necessary to carry out missions in adverse conditions. And this training remains a part of each veteran throughout their lifetime, and often really can inform their end-of-life experience. So there are values that get inculcated when a person is being brought into the military. Things like facing fear and adversity with courage. Controlling your emotions and tolerating discomfort is critical for mission success. So in other words, when you are in the midst of a battle or carrying out a mission, you don't have time to stop and say like, ow, this hurts, or wow, something terrible just happened to me or someone around me. If you stop to process that or even really experience it, it might put your life in danger. It might endanger the person next to you. It might endanger the mission. So controlling those things and kind of shutting off some of your experience is really key to carrying out the mission, because survival depends on staying alert and disciplined and obeying orders. Having an immediate reaction to change. Sometimes our veterans can be experienced as really reactive, but again, that's part of survival in the field. And that is your job. Your responsibility as a military member is to survive and to keep your fellow soldiers alive. And that I find is something that really never goes away for many of our veterans. Even to the extent that, and you may have seen this, that veterans who are terribly ill or really struggling to function will sometimes, when we offer them services, they'll say, no, that's for somebody else. That's for somebody who really needs it. There's this powerful sense of taking care of those around you. Combat skills are a piece of it. When our veterans are trained to inflict bodily harm and to kill people, and that is something that stays with them for the rest of their life, and something that we as providers just sort of have to keep in mind, that that's a different mindset that can resurface. Also, a big piece of the battle mind culture is about limiting discussion to the members of your unit. So you don't talk about what's going on with people outside of your unit. So, you can imagine that this really can influence end of life in so many ways. And caregivers can provide a really safe and trusted presence for exploring issues that can make a path for veterans and family healing by using some of these, like drawing on that self-confidence and mental toughness when someone is facing their final battle. remembering that emotional control and tolerating pain, these things are critical during combat, but that level of sort of shutting down that's necessary in the battlefield, when you come home, that can lead to relationship failures, inability to communicate emotion or receive interventions for pain or other symptom management. You've probably noticed a lot of our veterans can be really stoic, and sometimes aren't even going to tell us when they're suffering. Surrendering to the unknown or discovering what's right for a person, or going with the flow, experiencing peace and calm, those things are often associated with a positive death experience, but they can be very uncomfortable for some veterans who don't feel comfortable letting their guard down, right? Like all of these things we've talked about with battle mind, none of that is really consistent with like, be calm, be open, go with the flow. So the things that we might want for a person as they face the end of their life, they may not be the things that person wants, or that they may not be comfortable for that. And for some veterans, sharing their stories can be really novel and uncomfortable. So just remembering that those formative experiences stay with our veterans all the way through the end of their lives. So talking specifically about post-traumatic stress disorder, PTSD, I think the first thing I want to emphasize is that post-traumatic stress is a normal response to an abnormal situation, right? It's what we do when we are experiencing something way outside our normal experience. And PTSD is not limited to combat. Exposure to any trauma or terror, such as natural disasters, victims of crime or abuse, or even motor vehicle accidents, can experience PTSD. But specific with our veterans, PTSD was sometimes called shell shock or battle fatigue during World War II. In the Civil War, it was called soldier's heart, which I just find such a telling phrase. And so what we now know and sort of think clinically about PTSD is that the first piece of it is exposure to a traumatic event. And by trauma, we mean an experience where your life or someone else's life was in danger, and you responded with helplessness and horror. The next piece of PTSD is that this persistent re-experiencing. So that can happen through like recollections or like intrusive memories, or even flashbacks. This sense that because of the way the memories are stored, they pop back out as if they are absolutely happening again in that moment. That's what a flashback can look like. Sometimes these persistent re-experiencing takes the form of nightmares or even sensory distress cues. So I took care of a guy who was a veteran of Iraq and Afghanistan who experienced roadside bombs. And for him, the smell of gasoline was a really important trigger that brought on all these memories, because there was burning gasoline during these explosions. So for him, even filling up his car was super stressful, right? And so what do people do? Well, they persistently avoid associated traumatic stimuli. So thoughts, feelings, conversations about trauma, a lot of times our veterans do not talk about these experiences, and they avoid the situations that can trigger these distress cues. Like my guy who would drive a long way on fumes because just filling up his car was very distressing. You might find veterans that avoid things like war movies. 4th of July can be terribly stressful for people with those loud fireworks. Other persistent symptoms can include things like inability to recall some aspects of the trauma. Again, I won't get into it here, but the way traumatic memories are stored, they're not processed. They just get like shoved. They don't get neatly filed away. They get shoved in the back of a drawer. And then sometimes those things can come out in really distressing ways. Sometimes people with PTSD just feel really detached or estranged from other people. They can have kind of a restricted range of emotions and a sense of foreshortened future. We took care of a guy who served in Vietnam, and when we shared with him in his late 70s that his COPD was going to end his life soon, his family was really distressed, but he said, "I've known this day was coming since I was 19 years old." Like there's a sense that the specter of death has lived with them their whole life. And so that can also lead to things like difficult sleep patterns, irritability and outbursts of anger, concentration problems, hypervigilance and startle response. I'm sure you've seen this where people are not comfortable with their back to the door, or, and we'll talk about this in a little bit, but like in a hospice setting, like how do we set up a veteran's room so that they can see the door, or that they don't feel like they're being surprised? Because surprise is not good if you have PTSD. So PTSD onset can be acute. It can happen really quickly. It can be chronic, something that goes over years, or it can even be delayed. People can experience a trauma and then look like they're doing pretty well, and then something will trigger the resurgence of the PTSD. And how and when it shows up with people is not entirely predictable. And I should emphasize that in the population at large, the percentage of people who develop PTSD after a trauma is like less than 20%. So, I mean, humans are remarkably resilient, and not everyone who experiences a trauma goes on to develop full-on PTSD. It is worth noting, though, that soldiers with high combat exposure are 4 times more likely to have PTSD. So that combat experience can be really salient. Treatment helps. Ongoing support helps. And post-traumatic growth is something that we don't talk about enough, I think. Back in the 90s, some researchers, Tedeschi and Calhoun, formed this theory about post-traumatic growth, that sometimes in the wake of a trauma and in the wake of experiencing post-traumatic stress disorder, people can move through that and come through with a renewed appreciation of life. It can positively impact their relationships with others. They can develop a sense of new possibilities in their life and a new understanding of their own personal strength, and it can lead to spiritual change. So there are growth opportunities that come from trauma, but again, this isn't something we see with everyone. So trying to kind of get a sense of where an individual is really important. And particularly for us caring for people with illness and an end of life, it's important to note that when the trauma involved painful physical injury, that just pain in and of itself can be a trigger later. Also, I didn't put this on the slide, but things like breathlessness, like veterans who, like we took care of a guy who was in the Navy and was trapped underwater at one point and was able to survive and get out. But then later on in life, when he developed breathlessness, not only was that, terribly distressing in and of itself, but as a trigger for his trauma is really powerful. So just knowing that for some of our patients, not only is their present experience challenging, but it may have powerful echoes of past experience. So who gets PTSD? As I said, it's the estimated lifetime prevalence of PTSD among adult Americans is just 6%. It's low, right? 4% among men and 8% among women. And we don't have time to get into those gender differences, but I think that's worth noting. But you'll see that it's really different for our veterans. So 15% of Korean War veterans had PTSD, and an additional 17% had PTSD and depression. Estimated lifetime prevalence of PTSD among Vietnam veterans, 30% for men and 27% for women. So high numbers of folks. And remember, women served in Vietnam, women served in every conflict. Sometimes when we think of veterans, we think of men, and it's important to remember that that women are a large part of our veteran population and affected by all these things that we're talking about. Interestingly, kind of lower numbers for the Gulf War Desert Storm folks, about 12% experience PTSD in a given year. And this is such a huge range, but about 11 to 20% of veterans who served in Iraq and Afghanistan have PTSD in a given year. So just worthwhile noting that that military experience can be a risk factor for PTSD, and just because you have a veteran, and even if it's a veteran who was in combat, they didn't necessarily develop PTSD. So Deborah Grassman is a nurse practitioner who spent a long time at the Bay Pines VA, and she just has given a great deal of thought to veterans at end of life and different ways that they have processed their experience. So one response to trauma can be an integrated response. So these are people who say things like, I've faced death before, I'm not afraid anymore. Every day's been a gift. And when we're working with folks like this, we listen to them. We invite them to tell their stories. We celebrate their accomplishments with them. These may be people who've experienced some significant post-traumatic growth, or who've integrated it into their life experience. So we affirm that. Incomplete integration is people who still are really struggling, right? Who just have not been able to integrate what they experienced with their current life. Like people say, I lost my soul in Vietnam. I took care of a guy who was a Marine sniper who served in Vietnam. He was there during the Tet Offensive, and he was fully service connected for, like, in other words, considered fully disabled by his PTSD. And I asked him once, it was during the anniversary of the Tet Offensive, and he talked about feeling like he was there. And I said, how much of the time are you there versus here? And he said, oh, I'm here about 50% of the time. And the other 50% of his life felt like he was still in Vietnam, right? So there's this sense of, I'm never the same. My whole life is marked. These are people who might have a history of alcohol or drug abuse, difficult relationship history, suspicion and lack of trust. I have another veteran I take care of now who has PTSD from Vietnam. And he said to me, just completely serious, I've realized that I've never met anyone other than my wife that I can trust. Right. So these things stay with our veterans. And, you know, sometimes you see them with nightmares or sleeping on guard. These are folks who may be having ongoing treatment for PTSD, but there's still a lot of work to do. This third category, this is again Grassman's categories. This is an interesting category of sort of impairment integration. Like, in a way, it's easier to spot the first two categories, the people who say, I experienced a trauma, I've moved through it, I've integrated it into my life. Okay. Or the people who are like, I am still wrecked by this. Those people are easier to spot. But there's this third category of people who look like they're fine. Like, I don't talk about it. Everything's been fine except the time I had in the service. There can be these unsuspected lingering effects of war trauma that are undiagnosed or have a delayed onset. And these are people who use a variety of behaviors to keep the trauma hidden. So they might be a workaholic. They might be quite aloof. White knuckle syndrome, people who are sort of getting through life just like this. Actually just have been emailing this week with the widow of a veteran I cared for probably 10 years ago. And she came across a song called The War After the War, which is about the impact on spouses of people who have come home with PTSD. And in my work with her and the veteran years ago, I mentioned that there might be kind of unresolved PTSD issues kind of in passing. And she reached out to me a decade later to say, that was really significant because I didn't know how badly he was wounded from the war. And I'm not sure he even knew, but she talked about this experience of like trying so hard to heal him and not even knowing healing him from what. So just know that sometimes people come in and they're not talking about PTSD and their family isn't necessarily talking about PTSD, but they may still be experiencing effects from trauma. So how do we care for these folks? How do we take excellent care of them at end of life? So Feldman and Perry-Coyle from the Milwaukee VA have some great suggestions. So one is just asking, right? I have a colleague who says his version of trauma care is all about voices and choices. So hearing people's voice and giving them agency. So asking them, if you have someone who's a veteran, ask them, are there things that you find particularly challenging, particularly disturbing? Are there noises that set your teeth on edge? Do you hate to have your back to the door? Those kinds of things can be really helpful. Avoid sudden, unannounced loud noises when possible. You probably know this, right? But like, avoid, like, when a veteran is sleeping, like, instead of shaking them, stand at the foot of the bed and call their name. Just sort of gently, but progressively loudly until they waken. Some veterans may wake up in a startled state. They may swing their arms or jump. So standing at the foot of the bed keeps everybody safe. As a side note, dogs that are trained to be service dogs for people with PTSD, with veterans with PTSD, Canine Companions, the organization that Tootsie's from, now trains PTSD service dogs for veterans, and nightmare interruption is one of their tasks. And for non-veterans, when the person is having a nightmare, the dog jumps on the bed and like snuggles the person. And for veterans, what they figured out is the dog jumps on the bed, pulls the covers off, and sits at a distance from the bed until the veteran's awake. So, you know, not to paint our veterans as like super dangerous people, but just your impulse, if you're awakened and you're feeling hypervigilant, like your life is in danger, you may come out swinging. So just helping to avoid that experience of being abruptly startled and keeping everybody safe is really important. Cueing people, giving them a sense of what to anticipate. So before you make physical contact with a veteran, cue them about what you're going to touch and why. Sometimes we have to physically touch people. Sometimes it's important and welcome, but just again, giving them agency, giving them choice. Help the veteran have as much autonomy and self-direction as possible. So find opportunities to give them choices, even if they're immobile. Like, do you want to drink now or later? Do you want me to brush your hair? Do you want your arms or your legs washed first? Giving agency is really important. And then educating veterans and family members and staff about PTSD and how it can affect care. Like, you're not crazy. There's nothing wrong with you. These responses you're having, or these responses your loved ones are having, completely understandable, and we're going to take care of them. So other kinds of interventions that hospice staff and volunteers can keep in mind when caring for veterans, particularly those who have this kind of incomplete integration of trauma at the end of life. Remember, especially if they've disclosed trauma to you, remember that behavior can be affected by trauma. Limit restraints, especially if the veteran was a POW, that can be so triggering for people. So just helping them have as much freedom as possible. There are medications that can help, and so working with your medical folks to engage the use of medication to help with anxiety and depression. Recognizing the role of stoicism. We talked about this a little bit earlier, but just remember, if you feel like maybe someone is suffering more than they're telling you, you may have to do a little guesswork. Realize that noxious stimuli can re-stimulate trauma. So like environmental triggers, like a cloudy day, helicopters for our veterans in Vietnam, helicopters are incredibly salient. But it could also be something like the death of a roommate, or the experience of coming into the hospital, or the experience of nearing their own death. That level of vulnerability can really bring some trauma experiences to the fore. And so we keep them safe. We provide for physical safety, emotional safety, removing weapons from the environment, asking them what they find safe and reassuring in their environment. Like, do you want your bed in the corner so that you can always see the door? Great. Do you want your door open or closed? All those kinds of questions. And just being gently reassuring and present. If there are times when there's lots of emotion in the room, here's some useful guidance about just like remaining calm, reorienting people, like, I am, here's my name, here's where we are, we're in your home, or we're in the hospice facility, just helping people reorient. Our calm as caregivers can really help with our veterans' calm. And sometimes people are not able to settle, in which case it's okay to leave the room. It's okay to say, I'm going to step out because I think this interaction is challenging, and so I'll just come back when you're calmer. Because that can really give people a sense of safety and control. And just a few last words on the subject of PTSD. Non-combat veterans may have served on dangerous assignments. I think this is really important for us to remember, that sometimes veterans who technically served in a combat setting didn't see much action might actually feel guilty about that, might say, I didn't do that much. On the other hand, like, I had a veteran who served in the motor pool in Vietnam, and he was like, sweet, I'm not in combat. Except that he had to ferry vehicles back and forth to people at the front, and he was shot at all the time. But when he came home, people were like, oh, you were in the motor pool, you're fine. So like kind of the severity of his experience wasn't even recognized. So, and just a reminder to all of us about not making assumptions. And remember that not everyone who's suffered a trauma will experience PTSD. And know that it can just sort of pop out in ways and at times that can surprise the person, their family, us as caregivers. So just sort of keeping yourself grounded as you're caring for folks can be really helpful. So I'm going to shift away from the topic of PTSD. I don't know if we want to pause here if anybody has questions or comments about that before I move on to something slightly different.
Yeah, we do have one question about PTSD. Let me just pull it up real quick. Do you have any idea why the rates of PTSD are lower among the veterans of conflicts more recent than Vietnam?
That's such a great question. I don't know specifically. I think that, Vietnam, there was so much about Vietnam that was so incredibly difficult. Some of that, like jungle fighting, was, I think, was incredibly challenging, which is not to downplay the significance of the fighting in Iraq and Afghanistan. I also think that the ways that veterans came home from Vietnam was very, very difficult. For one thing, like you think about World War II, everybody's on a troop ship, right? So the war's over, you leave Germany or France or England, wherever you were. So you went and served with maybe people from your neighborhood or from your city. And you all served together. And then at the end of the war, you got on a ship and it took you a week or two to get home. And then you got home and people received you as heroes. Contrast that with Vietnam, where people were out in the field with people that they had no idea who they were. They didn't have a lot of opportunities to build that kind of sense of cohesion. And then when they came home, they were flown home. And so there's this very jarring, like I've had veterans talk about, like one day I'm in the jungle and, like a day and a half later, I'm wandering the streets of San Francisco. I had one veteran who talked about just walking around his neighborhood at night, like kind of seeing families through the windows and feeling like an absolute alien. So like their transition back home was very difficult. And for a lot of them, they received terrible responses when they got home. They were called baby killers. I had veterans talk about like getting off their plane and having sort of like having to walk through like metal fencing because people were throwing things at them. Veterans who said, like, I couldn't tell anyone I was a veteran because I couldn't get a job. So I think a lot of those things contributed. So it's not just the combat itself, but a lot of the things around that experience that contributed to that. That was a great question.
Yeah, thank you so much.
Yeah, thank you. And if you have other questions moving forward, we can address those. But I'm going to shift a little bit now from military culture and PTSD to talking about moral injury. So I don't know how many of you have heard this phrase. Moral injury is kind of a relatively new term. It's actually coined with regard to people serving in Vietnam. So moral injury is perpetrating, failing to prevent, bearing witness to, or learning about acts that transgress deeply held moral beliefs and expectations. As a veteran said to me recently, I had to do things that were against my sense of right and wrong. So we've talked about guilt and shame in relation to wartime experiences for centuries. Literally, you think about the Iliad talks about that. But just in the last decade or so, we're really trying to define and understand moral injury. But it's things that cause us to transgress our deepest beliefs. And then there's this harmful psychosocial spiritual aftermath. So having to do or to be unable to stop things that are counter to everything we believe in, that can just shatter your moral and ethical expectations, especially ones that are rooted in religious or spiritual beliefs, or culture-based or organizational beliefs about fairness, about the value of life. When I was a student here at the Denver VA, in our nursing home unit, I took care of a guy who was a Marine in the Pacific Theater in World War II. And he said, you know, your whole life, they tell you that it's wrong to kill people. And then you go to war and they tell you it's your job to kill people. And then you come home from the war and they tell you it's bad to kill people. There was sort of a sense that he had spent his whole life trying to make sense of that. I also, it affects people. I've always said that the things that our veterans see can be incredibly difficult, but it's the things that they've done that mark them forever. And people can feel really damaged after that. So moral injury versus PTSD, you know, they can coexist, and there's ways that there's overlap. So both moral injury and PTSD people can have like a strong reaction to reminders of the experience. They can have things like avoidance and denial, intrusive thoughts, negative thoughts about themselves like guilt and shame, anger, betrayal, and a negative view of themselves. And it can lead to social problems like trust issues or fatalism. Separately, though, moral injury is less likely to be related to life-threatening events. It's not so much about trauma where your life is threatened. It's more about activities, again, that transgress your deeply held moral beliefs. So there's more of a spiritual focus and an identity focus in moral injury. And the avoidance is not so much about, I don't trust other people, as almost the sense of, I want to protect others from me. I want to protect them from who I am. PTSD, on the other hand, is more likely to be related to life-threatening events. And the avoidance is about preventing re-injury. So how do I keep myself safe? So in a way, PTSD kind of has more concrete symptoms, and moral injury can feel a little more amorphous, in part, I think, because there's this more like spiritual or existential aspect to it. So veteran experiences that could lead to moral injury. You know, it's not surprising, right, given the context of war, that that this is highly prevalent among Vietnam veterans. So one experiences perceived betrayal by peers or leadership or civilians, or yourself, such as being ordered to break the rules of engagement, or having the experience of kind of feeling a rush or enjoyment during war and killing. That people do experience that, and then it can be incredibly disturbing. The experience of having to make decisions that affect the survival of others, the betrayal piece, feeling like your leadership made decisions that were not keeping you safe or didn't keep your troops safe. Those things can absolutely be injurious. Acts of disproportionate violence. So, I mean, you think of like the My Lai massacre or those kinds of things, like mistreating civilians or captured enemy combatants. And honestly, that happens in every war. Incidents involving death or harm to civilians. Again, we like to imagine that it's one soldier shooting at another soldier. That's not how war plays out all the time. But when someone has to engage in killing or injuring civilians, that can stay with them, especially if it's children. And sometimes moral injury is just wishing you had done something that you didn't do, like failing to perform a duty or not being able to save your fellow service members. So all of these are kind of like soul injuries. So what does this look like at end of life? You know, as I mentioned earlier, life review is something that we really value often in end of life care. But for some people, life review just reactivates these wounds. A lot of times people who experience moral injury feel as if they're unable to forgive themselves or they can't be forgiven. I've had multiple veterans nearing the end of their life say things like, I don't even know if I want to talk to the chaplain because I'm afraid to face God. I don't know if God can forgive me. You know, they feel that they're not redeemable. And they certainly don't want to open up to folks about their experience. And they sometimes can feel a sense of despair. So what do we do for those folks? There are therapies, things like meaning-centered therapy that really help focus on the meaning that a person has in their life and how they've developed a sense of meaning over the course of their life, kind of reconnecting people with their spirit and their purpose. That's a specific type of psychotherapy, but I think sometimes even informally when we're working with veterans, sometimes getting folks talking about like what's been meaningful in your life. What are the things you've done that you feel good about, that you feel proud about, helping them see the parts of themselves that are good and redeemable and lovable. And sometimes, honestly, really honoring when people say, like, I don't want to open that. I had a veteran say, like, he described his interior as like a series of boxes with different color ribbons on them. And he's like, there's some that have a red color ribbon and I'm never going to untie that ribbon. I'm like, okay, I will not ask you to untie that ribbon. So sometimes it's about respecting their choices. Do you have, I'm going to shift a little bit in a minute, but any questions or responses about the notion of moral injury?
Yeah, we have a few, but if you want to keep going, we can wait them for the end.
Okay. All right. Well, then I will shift to military sexual trauma. I reached this point and I think, oh my gosh, I'm so appreciative of you sticking with me because this is not the most fun or cheerful way you've ever spent an hour of your life. So thank you for sticking with me and thinking through some of the difficult things that affect our veterans. This is the last main thing I want to talk about. So military sexual trauma, it may be something that you've heard of. Military sexual trauma is defined as sexual assault or repeated threatening acts of sexual harassment that occurred while in the military. And there's a whole range. There's the range from, sure, I can put in those papers for your promotion if you'll go out with me, to, unwanted touching, to sexual assault, to rape. There's a wide range of experiences, including requests for sexual acts to things like achieve rank, prevent knowledge of homosexuality. A number of our veterans served during the time of like don't ask, don't tell. And it was a career-ending threat to be outed as gay, real or not. Or sometimes sexual acts to prevent harm to and from others. So like nothing, I'd hate for something bad to happen to your friend, right? So there's kind of a range of the trauma experiences that people can experience in the military sexually. Most commonly, military sexual trauma is experienced by women, but remember, we have a lot more male than female veterans, and so more than half the survivors of MST are men. So I think that's something really important to remember, that when you are dealing with a veteran, no matter who they are, it's important to remember that they may have experienced military sexual assault. Per a report, this is a little out of date now, but in 2006, the Department of Defense found that 27% of men and 60% of women have experienced MST. And people are up to 6 times more likely to develop PTSD from military sexual trauma than from combat trauma, particularly men. Men who experience military sexual trauma are at very high risk of developing PTSD. So what gets in the way of, if military sexual trauma is so prevalent, it is being reported more, but there's a lot of barriers to reporting. One is cohesiveness of military units, because it's often a member of your own unit who's done this to you. The perpetrator may have been your superior, in which case, where do you go? And sometimes when MST is reported, no action's been taken, or the only action is against the victim. So it can really like sort of re-victimize and re-traumatize people to report. But then when they don't report, then they carry this for a very long time. So mental health sequelae, there's lots, right? So PTSD, panic disorder, unsurprisingly, or even a more like generalized anxiety disorder can be a result of experiencing sexual trauma. Depression, sometimes people who experience MST are at higher risk for suicide. Also the kinds of things that are about numbing and disconnecting from your body, things like substance use disorder or eating disorder. Physically, this shows up in our bodies. So chronic pain is really common, particularly things like low back pain and headache, this general like malaise in your body. Gastrointestinal symptoms are very common with survivors of MST, particularly things like irritable bowel syndrome. It's like sort of your gut, the very center of your being, is affected by this. Gynecologic things that we see are things like menstrual disorders or pelvic pain. So that experience gets carried in the body. And particularly salient for us caring for people with illness in an end of life is to know that medical procedures can be really problematic in patients with a history of sexual trauma. The patient-provider relationship itself resembles some aspects of the victim-perpetrator relationship. There's a big power differential. Procedures can be invasive. Sometimes they can be painful, and the patient can experience a sense of lack of control over the situation. So if you are experiencing responses from people that feel like sort of not entirely proportionate to the situation or seem surprising, even if they haven't disclosed MST, it's important to recognize that that's a possibility. So how do we respond? So responding with empathy. If people do disclose to any of us, we respond with empathy. I'm sorry this happened to you. I'm here to listen to your story if you want to tell it. And in my experience, I mean, I have a couple of veterans that I worked with literally for years in the context of their serious illness before they disclosed additionally that they experienced military sexual trauma. So it could take a very long time, but if someone is willing to trust you with that, then we respond with trust. We ensure privacy, sometimes even just in our routine experience interactions with patients, making sure that privacy is honored, listening if they're willing to share, and knowing our limitations. This just knowing, like, sometimes you want to say, I'm going to go get somebody else who's able to like offer more professional support around this. Or also, like, hearing these stories can be very hard for us as providers. And so knowing what you're okay to hear and what you're not. And all of these things can be just an incredible gift. I think sometimes, especially for people at end of life who carried this for a long time, they might find it a great relief of a burden to have someone they trust enough to share that with. So that is all I have to say about that. Why don't we, I know we have about just a few minutes left. I think I'll actually stop sharing my screen if I'm clever enough to do that. Oh, good. Yay, victory. And I can see people have put some stuff.
Yep.
Let's see.
So do you want me to read some questions?
Let's see. I see one from Carrie, the World War II guy who's talked about killing is wrong. It shows all the way back to that war, and since the military does not do a good job of helping soldiers reintegrate into society. I think that's true. I mean, I think the military is getting a little better and trying to be more thoughtful, but it is, I mean, it's just a really fundamental shift in role, right? And one of the things that was so difficult, as an aside, for our Iraq and Afghanistan veterans, that veterans of earlier wars, including Vietnam, didn't have to deal with, is repeated deployments. So when you may not be seeing many of our Iraq and Afghanistan veterans now, they may be in your pipeline later, but World War II, you just stayed, and Korea too, until it was done, and then you came home. Vietnam, you were there for a year. Iraq and Afghanistan, a lot of our folks, they serve, they're deployed for a year, then they come home, and then they go back. And then they came home, and then they went back. And so that shifting between battle mind and then like, oh, now it's time to go to work and go to the grocery store and go to the soccer game. You can imagine how incredibly jarring that is. Kathy's got a comment. We have a patient on care who experiences guilt and lashes out because he was held back and turned into instructor after training instead of being deployed to Vietnam. Yes, yes. Would that be considered a moral injury? I think it can be, or certainly like moral injury or maybe a survivor's guilt kind of thing. Because yeah, some of our veterans have this tremendous sense of guilt if they were not in harm's way, if they, like in this case, were held back from being in combat or had an injury that took them out really soon. That also can really be a very painful thing for them to carry. And it's hard because most of the people around them they're not going to share that, right? Like if you were in combat, people kind of get it. Oh, that must be hard. But if you didn't go fight, people might be like, yay, that's fantastic, and not understand that level of internal distress. So that's a really great point, Kathy. Thank you. Beth's comment, art therapy can be incredibly powerful, just like the example with the boxes and ribbons. Yes, there are. So I'm a psychologist, right? So I'm all about words, blah, blah, blah. And I happen to think words are useful, but you'll notice I also have a dog. Like, because there are times that words are not equal to the task. And so art therapy, music therapy, there are so many ways that we communicate, that we process, and that we care for each other and ourselves that are not verbal, that I think those things can be incredibly important. Kim's question, how do you emotionally prepare a veteran with MST for Foley insertion? Great question. I would really go back to the voices and choices piece, like helping them understand why it's indicated, helping them understand what to expect. Through my work with Tootsie, I've gotten to know there's a number of people who work with dogs like her who are child life specialists in children's hospitals. And I'm like, golly, Pete, we need child life specialists in grown-up hospitals. Because what those people do is like, if a kid's gonna like have a Foley insertion, they'll bring the Foley, they'll bring the tubing, like a sample, and they'll show the kid and they'll let the kid handle it and play with it. And, or, if it's like an injection, they'll kind of give the facility dog a little fake injection. Like, here's what it's going to look like. Here's what it's going to feel like. Here's what it's going to sound like. I think that should be present for all adults, but especially in that kind of setting with MST and the Foley insertion, helping them understand exactly what to expect and getting clear in advance maybe on, can they stop the procedure? Because again, it's all about control and agency. Gretchen, you're trained in teaching yoga for warriors. It's very moving, no pun intended. That is awesome, right? Anything that helps us be in our bodies, connects us with our breath. You probably know more than I do about like the vagal nerve. We're just learning about the importance of the vagal nerve and that connection with the vagal nerve is like this big nerve that runs down the middle of your body. And actually, like, it's the main piece of feedback back up to your brain from your body. But we're learning more and more about the vagal nerve and its involvement in our emotional well-being. Like when we say like, I have this gut feeling, we're probably talking about what our vagal nerve tells us, right? So yoga is a fantastic way to activate that. Oh yeah, The Body Keeps the Score is such a good book, Bessel van der Kolk's book about trauma. Yeah, we are embodied creatures. And I think, you guys know this, right? Working in hospice, you see this all the time, that whatever kind of false dichotomies we have about brain versus body or mind versus spirit, whatever, you know that we are integrated, and caring for our whole selves is so important. Jolie, I don't know if I saw the question.
I have the question for you.
Okay.
Her question was, does moral injury include veterans that have a hard time accepting gratitude when they made it back and their brothers and sisters did not? Her particular runs into a lot with this situation during recognition ceremonies.
Yes. Oh, that's so important, right? Yeah. Thank you for making that connection. I hadn't thought about that connection, but I think you're right. Um, or yeah, that and or like the piece of survivor guilt. Yeah, sometimes when we thank people, yeah, they say, no, I'm not the hero, right? The heroes are the people that didn't come back. So I really, gosh, I so appreciate your sensitivity to that. And I think when I encounter that with folks, I try to just meet them where they are and say, it must be so painful. It must, I wonder what that's like to miss those people, or to say, in this, if we're having like a recognition ceremony, I'd encourage you to, if there's particular people that you lost, to hold them in your heart, and maybe even in a recognition ceremony, recognizing all those who gave that last full measure of devotion. I think that's really important.
Thank you so much. And we got one more question for you is, how would you suggest asking about things that trigger veterans without triggering them at the same time?
Right. That's such a good question. I think just a really straightforward, especially if you know someone's a veteran, saying some of our veterans have had experience in the military that affects them even outside the military. And so I wonder if there's particular ways that we can help you be comfortable. And sometimes even offering up, like you can say, like, some of our veterans don't like to have their back to the door. Some of our veterans don't want us to touch them if they're sleeping. Just asking in a really straightforward way, like, what's going to help you feel comfortable. You can also sometimes ask family members. Sometimes, this isn't unique to veterans, it's true for all of us. I think that we don't necessarily know ourselves that well. I teach seminars on self-care for our learners, and I encourage them to know there's like signs of stress. And I say, if you don't know, ask your family, because they do. Like, what do you look like when you're stressed out? Or like, what things are going to kind of trigger you? If you don't know, ask the family, because they can say, this particular sound always upsets them, or they really don't like foods. There's some kinds of foods that just are very triggering for people, and they may not even be able to be aware of that. So you could ask them, like, hey, is it okay if I chat with your family? And just ask, how can I keep you really comfortable?
That was excellent. Thank you so much. Catherine, did I miss any questions you saw in the chat box today?
Nope, you got them all, Em. Thank you.
Awesome. Great. Do you want to add anything else, Dr. Holman?
No, other than thank you so much. I really, Em and I were saying before we got started that it's always hard. It's awesome to do Zoom because you can, like, such a fantastic range of folks here from all over the country. And it's weird, right? Because you can't see people's faces and you can't make contact. So thank you so much for rolling along with us, for participating. And it's just really such an honor to be part of this. Thank you.
Thank you so much for presenting, and thank you to all the partners who attended. This webinar is recorded and will be added to our website shortly. And I hope you all have a great rest of your week.
Thank you so much. Take
Thank
care.
you.
Thanks. Bye-bye.